Today's lecture is on medical records and documentation. The importance of medical records. The patient record or chart holds the medical history and present condition of the patient. Legal guidelines include the documentation of care, evaluation, patient instructions, and noting if the patient is non-compliant by not following the medical advice. Standards for records are to make sure they are complete, they are accurate, they are well documented, and all records are the physician's responsibility as well as owned by the practice. Additional uses of patient records. We use patient records for patient education. Tests are there, whether they're lab tests or diagnostic tests. Test results are tracked. Study uncommon conditions. The information from records are gathered in a non-disclosure manner to show the different types of conditions, especially uncommon ones, and the trends in those conditions. The quality of care. We audit these records. It's for care analysis and the basis for future policies and plans. They're used for research in patient responses, behavior, symptoms, side effects, and outcomes. The contents of the patient medical record includes the patient registration form with basic demographic information. Demographic information includes name, address, date of birth, gender, person to contact in case of an emergency, social security number and insurance information, employer and contact information at your employment. Initial information is rechecked with each visit. Your patient medical history includes illnesses and surgeries, allergies, are you on current medications, family medical history, social, occupational history, a history of present illness and the chief complaint, or as we say when rooming a patient, what brought you in today? The physical examination form has a review of symptoms, and this is an inventory of status through series of questions, and the physician exam verifies the answers. The results of laboratory and other tests, outside sources, record on flow sheets for ease of tracking, documents from other sources, authorization for release of information, records from other physicians and hospitals. The diagnosis and treatment plan are part of the patient's medical record. Assessment determined after study of subjective and objective findings. A treatment plan can include options and different ways to get things done. The operative reports, follow-up visits, and telephone calls. All procedures and surgeries are documented, progress notes are documented and signed, and patient contacts are documented, meaning did the patient contact us or anything, and did we contact the patient? So everything involving a patient is in that medical record. Hospital discharge summaries. The reason for the hospitalization. You had to have your appendix out. The admission and discharge date, the admitting diagnosis, the history of the illness, test procedures and operations that may have been performed, medications that may have been given, outcomes. Were there any complications? What was the final discharge diagnosis? Patient follow-up instructions, and the discharging physician's signature. Consent forms all need to be signed in witnesses by a licensed practitioner, whether it be a nurse, physician, or physician's assistant. Correspondence with and about the patient from other providers and laboratories. All these correspondence need to be marked and stamped with a date. Information received by fax, dating and initialing needed before filing to show that the physician saw the information. Maintaining confidentiality for patient rights. These are 6 rights: the right to notice of privacy practices, the right to limit or request restriction on protected health information use and disclosure, the right to confidential communications, the right to inspect and obtain a copy of PHI, the right to request an amendment to PHI, and the right to know if PHI has been disclosed. Types of medical records. We have source-oriented medical records, or SOMRs, and this contains patient information arranged according to the supplier of data. So if the lab came in first, well, that's on top, and then imaging, and then another doctor's office. So it contains information arranged according to supplier of data. Progress notes are in reverse chronological order, and there is one section for each department sending information. Now, problem-oriented medical record is set up differently, the POMR. This is a database of history, physicals, and tests. The problem list, each listed separately. Signs are objective, symptoms are subjective. Educational, diagnostic, and treatment plan are included, and progress notes are done in the SOAP format, or the SOAP format, which we'll discuss now. Subjective, objective, assessment, and plan. This is the SOAP format for patient visit. Subjective data is from the patient, starts the SOAP note. I'm here because my head hurts. Objective data is from the physician, the exam, and the tests. The assessment, diagnosis, and impressions are gathering of subjective and objective data. And the plan of action is treatment options, medications if needed, more tests ordered, consultations, and the patient education and follow-up. SOAP. Now, the Cheddar form breaks the SOAP down into chief complaint, why are you here today? History, how long has this been going on? Examinations, what did we find? Details of the problem, drugs and dosage, if you need an antibiotic or other type of medication. The assessment, here's the plan. And your return, visit, or referral. This is the Cheddar form, which breaks down the SOAP note. Documentation and the 6 C's of charting. Updating medical forms, documenting test results, examination preparation, and vital signs. These need to be done before the practitioner sees the patient. Here's the follow-up. The 6 C's. Put the complaint in the client's words. Don't change it. Put it in the client's words. Clarity. Ask for clarification if needed and write clearly. Completeness, conciseness, chronological order, and confidentiality. These 6 C's must be maintained. Appearance, timeliness, and accuracy of records. Neatness and legibility. Medical transcription means transforming spoken words into written notes, and handwritten notes are done in blue ink. Timeliness. Get these taken care of with the patient in the room. Make sure they're accurate and use a professional attitude and tone. Correcting and updating medical records. Using care with corrections. Mistakes are not uncommon, and you make corrections according to office policy. Most corrections are made with putting one line through the error, printing the correct information, the date, and your initials. Printing the information. And then updating patient records as information comes in. These are for paper medical records. We do use electronic medical records now, and a lot of this is taken care of in the EMR, as you will see. Responding to release of records request. Procedures for releasing records. Obtained, assigned, and dated release. One more time. Obtain, assigned, and dated release. And this is usually done at the front office. Photocopies of requested material have to be made, and you call the recipient to confirm that materials were received. Most medical records these days are electronic, and the patient has access to them on the patient portal. Confidentiality for special cases. If in doubt, check with the supervisor. Don't do anything you're not sure of. And protect each patient's right to privacy as if it were your own record. Auditing medical records. Internal audits can be done by staff and by the risk management department and the quality assurance department. Prospective audits are done before billing, and retrospective audits are done after billing. We can have external auditors come in from different areas. We can have Medicare come in. Medicare likes to come in and audit patient records, as well as Blue Cross Blue Shield. The government entities are Medicare and Medicaid, and then there's the private carriers, as mentioned. This ends today's lecture on medical records and documentation.